I'd like to begin by reviewing some key points and take-home lessons, which is that head and neck infections are actually quite common in pediatric practice and in inpatient pediatric populations. These complications are rare, but they're potentially life-threatening because of their strategic position. The clinical features of these illnesses generally reflect the localization of the infection. It's important for us to make these diagnoses in a timely way, and cross-sectional imaging is generally crucial and important to obtain in a timely way. This is a team sport. We have to get consultation from our ear, nose, and throat colleagues, as well as, in some cases, ophthalmologic and neurosurgical consultations as well. The microbiology is in some ways the least interesting. We commonly deal with mixed infections. As you can see, a variety of gram-positive and gram-negative organisms. Because of the broad spectrum of potential infection, we are committed to using broad-spectrum antibiotics. And oftentimes, the cultures are less revealing than we might like because children have received antibiotics before they undergo surgical drainage. The current crisis in drug resistance with methicillin-resistant staph and resistance among other gram-positive organisms and among gram-negative organisms complicates our empiric management. I'd like to begin by reviewing some definitions. We can talk about infections in terms of their roots, that is where they begin, and also where they end up. And each offers certain valuable points in terms of their microbiological etiology, the mechanism of the infection, as well as the details of surgical management. So, for example, if we think about dental infections, I've listed on the left a number of different anatomic spaces that you can see here. That there will not be a quiz on these at the end of the hour, but simply to say that infections that originate in relation, for example, to their parotid space can progress beyond their fascial borders and involve deeper structures within the head and neck. And it's important to recognize these potential complications. Similarly, tonsillitis may progress to a peritonsillar abscess formation, which, if it proceeds posteriorly, will generate a retropharyngeal abscess, and if it spreads laterally, we will confront a parapharyngeal or lateral pharyngeal abscess. Sinus infections can spread to the orbit, or they can spread to intracranial locations, as I've listed here. And each of these specific entities has its own clinical features and its own implications in terms of management, both medical and surgical. And otitis media, a commonplace infection, generally not very complicated and not very life-threatening, can in fact, on rare occasions, proceed to produce a variety of deep infections that can involve the intracranial vault with life-threatening complications. So I'd like to just define or review some simple definitions, which is that all of these potential spaces in the head and neck are bound by fascial layers. These fascial planes define potential spaces which may actually become infected in the form either of cellulitis, which we would recognize on scanning as an inflammatory mass or phlegmon, or as a frank abscess, which implies the benefit of surgical drainage. These compartments often contain or abut critical structures that will be compromised and, in fact, threatened by the inflammatory process. So in this simple schematic diagram involving the teeth and their relationships within the oral cavity and the head and neck, you can see that infections that spread from an apical abscess may spread into the spaces, the parotid space, for example, or the buccal space or the masseter space, depending on the precise involvement of a particular tooth, or may involve spaces within the floor of the mouth in the infralingual space here. And you can see on this lateral view that whether infections tend to rupture outwardly or rupture inwardly depend on their anatomic position. So, for example, Ludwig's angina tends to involve the initial molars that are present, and the molars present in teenagers and young adults tend to spare the floor of the mouth and to rupture externally. These diagrams define for us in somewhat excessive detail of some of these potential spaces, but they demonstrate, importantly, the relationship of critical structures as they sit next to some of these potential spaces. And I've circled the lateral pharyngeal space, which sits just lateral to the tonsillar fossa, and the retropharyngeal space, which sits, of course, behind the pharynx. And you can see that the critical neurovascular structures sit in close proximity and may be compromised by serious infection. And this simpler schematic defines some of these spaces and the relationships to some of the normal structures involving the oral cavity and the throat. I begin in terms of specific infections saying a few words about Ludwig's angina. This is not common in children, but because it often involves infection in the apical spaces of initial molars, it can involve the floor of the mouth. And as I've mentioned, it usually involves the sublingual space and the submandibular spaces. It is notable for a lack of pus. It forms what has been called woody induration, and it's one of those things you have to see it to believe it. The tissue is markedly inflamed. It's hard as a rock, and the patients are typically quite ill. It's recognized at the bedside by marked facial swelling, by displacement of the tongue superiorly and often anteriorly with complications of dysphagia and dyspnea. The strategic location of this infection threatens the airway, and these children need to be either intubated, subjected to emergency tracheostomy on rare occasion, or managed at very close watch in the ICU. The patients, of course, need medical therapy with appropriate antibiotics and often undergo local exploration with placement of wicks, although typically the surgeon does not really encounter copious purulent discharge. And this demonstrates typical findings of a patient with sort of Winston Churchill-like jowls suddenly appearing with mild or marked overlying erythema, but it's on palpation that you appreciate the striking induration of this space. CT scanning demonstrates dramatic changes in these patients, and here you can see very widespread heterogeneous inflammation in the sublingual space. And on the lateral, you can appreciate that this can widen or extend posteriorly and compromise the airway, hence the need for critical attention to maintaining a patent airway. I'll move on and talk about cervical lymphadenitis, which comes in two fundamental forms. That is acute cervical lymphadenitis, typically seen primarily in young children, and subacute or chronic lymphadenitis, which involves children of a wider age range. Typical bacterial cervical lymphadenitis presents to attention following a brief duration of illness with the onset of fever and almost always unilateral findings of acute inflammation, marked tenderness, and on CBC evaluation, leukocytosis. Imaging by ultrasound is easy. By CT scan, depending on the age of the child, may or may not be easy, but almost always demonstrates an inflammatory mass in the area that one can palpate at the bedside. The vast majority of acute cervical lymphadenitis patients have bacterial infection, and these are almost always gram-positive organisms. Staph aureus and group A strep, and a mixture of oral and facultative oral streptococci would be most common. The mix makes it hard to say whether this is a complication of an oral infection, such as teething or gingivitis, or whether this is a result of initially minor skin trauma with progressive deeper infection due to Staph aureus or group A streptococci. We no longer needle these nodes for microbiological diagnosis because we have a longstanding appreciation that these are almost always gram-positive infections. If ultrasound or CT scan demonstrate that this is a phlegmon and not a frank abscess, we generally simply hospitalize these patients and treat with parenteral antibiotic therapy, typically trying to cover both staph and strep, and in the current era we often use vancomycin initially to cover the potential of methicillin-resistant Staph aureus. Drainage is indicated if the lymph node is fluctuant, but often the node is still rock hard and exquisitely tender without evidence of purulence on imaging. Sometimes CT scans overcall the likelihood of purulent collection, and the surgeon may actually encounter a low-density phlegmon rather than a truly drainable abscess. So we try to hold off on drainage until it's pretty clear that this is necessary. And most cases actually do not need to undergo surgical drainage, in fact. It's interesting that the initial response is often painstakingly slow. Parents and residents get upset because very little seems to be happening, and I think this is due to the marked enlargement of the lymph node, the capsular stretch, the increased pressure within the lymph node, and the compromise of perfusion and the delivery of antibiotics, granulocytes, and so on. A little bit of improvement leads to a little bit of reduction in the volume of the node, better perfusion, and the response is typically nonlinear with initial slow and then more rapid satisfying response, and these children can complete a course of oral therapy as an outpatient. It's always important when we see a child who presents with several days of fever and lymphadenopathy to think in passing about Kawasaki disease. Classic Kawasaki disease is relatively straightforward to recognize, but atypical or limited Kawasaki disease is often a challenge. It's also important to think about uncommon causes because the management, particularly the antibiotic management, may be quite different. So we always like to get a travel history, particularly in the summertime when children may be off on vacation in faraway places and may have exposure to animals or to rural or rustic environments that may have rodents and potential exposure to unusual pathogens, as I've listed, such as plague or tularemia. It's also important, particularly in younger children under a year of age, that cervical lymphadenitis, particularly cases that don't respond to vancomycin therapy, may be a reflection of underlying immunodeficiency and are due to a gram-negative pathogen. So when children fail to respond to initial medical therapy and undergo drainage, and rather than growing out staph or strep, we recover an organism like Serratia or Candida, it's time to start assessing granulocyte function, looking for inborn errors of granulocyte function, such as chronic granulomatous disease. When children have a more subacute presentation, the age range is often broader, and the differential diagnosis is often quite broad as well. It is uncommon for these children to have typical staph or streptococcal lymphadenitis, and commonly such patients are given a course of oral antibiotic therapy without significant improvement. The differential that we encounter most commonly probably includes a non-tuberculous mycobacterial infection, on rare occasions human tuberculosis, and pathogens such as cat scratch disease due to Bartonella henselae or toxoplasmosis should be considered. These are diagnoses in the case of cat scratch disease and toxo that can be made by antibody testing. For a non-tuberculous mycobacterial infection, we actually need to culture tissue to make the diagnosis. In general, we recommend, if possible, excisional biopsy rather than incisional biopsy, because when non-tuberculous nodes are incised, the granulomatous inflammation compromises wound healing, and children are often left with intermittent drainage or unsightly scars, in contrast to a clean excisional procedure, which allows for satisfactory healing. The position of the lymph node relative to the facial nerve often determines how aggressive the surgeon may be in excising the node in question. And this little diagram just demonstrates that lymph nodes are all connected, and it's actually not all that easy to deduce the primary pathogenesis as well as the etiology of the lymph node swelling based simply on the site of cervical infection. This little collection of pictures demonstrates on the upper left the giveaway of Kawasaki disease with a very large node here and cherry red lips and tongue. The eyes are cut off, but I suspect they would be diagnostic as well. This very well demarcated, markedly inflamed erythematous node is characteristic of non-tuberculous mycobacterial infection, although this could on occasion be seen with cat scratch disease as well. It's often fluctuant by the time it reaches this stage, and it's desirable to have the surgeon explore this area before it spontaneously drains on its own, leading to A, a mess, and B, a potentially unsightly scar. Very often when we see a lymph node of this sort, Ultrasound or CT imaging will demonstrate a collection of inflamed nodes deep to the visible node, and we can or can't excise the bulk of this depending on their precise location and the willingness of the surgeon in question to explore the area definitively. I'd like to next speak about peritonsillar abscess. This is actually the most common suppurative head and neck infection seen clinically. This is a problem mostly of older children, preteens, and adolescents, although it can be seen in younger children. It is relatively commonly associated with infectious mononucleosis, but of course the majority of patients, in fact, don't have mono at the time that they present this way. It also can be associated with group A strep infection, and so there's often unsatisfying initial course of management where patients are treated for conventional group A strep infection. They may improve and then they get worse, and then they're retreated with a stronger antibiotic, and they improve and then they get worse, and it's not until some time elapses that it's clear that there's a deeper infection and not simply relapsing group A strep pharyngitis. Patients present typically with symptoms of acute pharyngitis followed or dominated over time by the development of asymmetric complaints. They will have pain that localizes more to one tonsil than the other. They will develop pain and difficulty on swallowing. They will develop muffling of their voice, the so-called hot potato voice, due to swelling of the soft palate. And depending on the extent of infection, they may develop trismus due to inflammation of the internal pterygoid. These children are often febrile and systemically ill. One doesn't need fancy imaging to make this diagnosis. In principle, a simple look into the mouth, if the child's old enough to cooperate, demonstrates classic findings of asymmetric tonsillar enlargement with displacement of the uvula to the opposite side of the oral pharynx. There's often marked edema of the uvula as well. One may or may not see an exudate on the tonsillar surface. Its absence does not exclude this diagnosis. A CT scan is sometimes performed to get a better sense of the extent of infection, and as you can see, there are at times well-demarcated areas of low density consistent with a collection deep in the tonsillar fossa, and you can see that there's marked swelling and low density of the adjoining tonsil on this slide. So the management is determined in part by the stage of infection. Peritonsillar cellulitis, a term to describe a phlegmon in the area of the tonsillar bed, can be treated medically. The presence of a frank peritonsillar abscess mandates, ideally, a drainage procedure. There's been a long-standing debate as to what the best drainage procedure might be. Needle drainage, acute tonsillectomy, delayed tonsillectomy. When these questions arise, a CT scan can demonstrate the extent of infection and whether a frank abscess is present. And in that case, in fact, simple needle drainage at the bedside together with IV antibiotic therapy is generally most cost-effective. The teaching that children with peritonsillar abscess have to undergo tonsillectomy in a mandatory fashion is now out of vogue. The risk of recurrent tonsillitis or recurrent peritonsillar abscess in children who've had one episode is actually relatively modest, in the 10 to 15% category. And so most children will not require tonsillectomy following a first episode of peritonsillar abscess. And we generally reserve tonsillectomy for children who have had recurrences, as noted. And here you can see in this little diagram the presence of the tonsil and the concern about a peritonsillar abscess deep to the tissue. I'll say a few words about the parapharyngeal space regarding its anatomy, which helps explain why we freak out about the parapharyngeal space infections. The lateral pharyngeal space, or the parapharyngeal space, has been described as an inverted cone with its base at the skull and its apex down at the hyoid bone. And you can think of it as having an anterior compartment and a posterior compartment. Involvement of the anterior compartment leads to trismus because of its involvement of the masseter muscles and the internal pterygoid. And the posterior process is actually the one that we worry about because it's close to the neurovascular bundle of the internal jugular, the carotids, and so on. And so this little diagram demonstrates the cone would be kind of perched at an angle with its base here and its apex down at the hyoid. And you can see that the posterior aspect of that cone involves the carotid sheath, and that the anterior aspect is abutting the masseter muscles and may produce trismus. So it's when present, trismus is quite helpful in terms of recognizing these infections and proceeding to appropriate management. Lateral pharyngeal abscess is an uncommon process in children, but it occurs often enough for us to always be vigilant in this regard. At the time that we recognize a lateral pharyngeal infection, we often are unclear as to the primary focus of infection. And as you can see, I've listed a number of potential primary processes that may progress and lead to the development of a lateral pharyngeal abscess. It's important to take a careful history and to try to identify an initial problem that may lead to adjunctive treatment, such as the presence of an initial dental abscess with the need to extract a tooth, or the presence of penetrating trauma and ascertainment of a foreign body, and so on. Patients with a lateral pharyngeal abscess often present with a tender neck. They have visible swelling and firmness. They have sore throat, dysphagia, altered voice, trismus, as I mentioned. They often have more concerning regional complaints with respiratory distress, drooling because of difficulty swallowing. They may even have unilateral vocal cord paresis and be hoarse, and often have an easily palpable cervical mass. These children are quite ill with fever and marked clinical toxicity. And because of the location of the infection, there are life-threatening complications to be concerned about. These can erode into the carotid and produce life-threatening hemorrhage. They could lead to inflammation and thrombosis of the jugular vein, which we'll discuss at some length, and named Lemierre's syndrome. And the infection can spread from the lateral pharyngeal space medially and enter the retropharyngeal space, which can then descend inferiorly, resulting in mediastinitis. So is Lemierre's disease Lemierre's syndrome a forgotten disease? Lemierre's syndrome is classically defined as a primary oropharyngeal infection with secondary anaerobic bacteremia, almost always due to the classic pathogen Fusobacterium necrophorum. The hallmark of Lemierre's syndrome is that there's thrombosis of the internal jugular vein. And once this develops, there is commonly metastatic infection at a distal site. And we will review some of these in a moment. Although this is the classic description that Lemierre used, the syndrome of a primary infection with resultant anaerobic bacteremia, venous thrombosis, and metastatic infection has been applied to other foci of infection. And I've listed some of the typical non-oropharyngeal Lemierre syndrome sources on the slide. This is a quote from Lemierre himself. The rigor usually occurs on the 4th or 5th day after the beginning of the sore throat, occasionally as late as the 8th or 12th day, by which time the tonsillar inflammation appears to be cured and the initial fever has disappeared. To anyone instructed as to the nature of these septicemias, it becomes relatively easy to make a diagnosis on the simple clinical findings. It couldn't be stated in a more concise fashion. The appearance and repetition several days after the onset of a sore throat, and particularly of a tonsillar abscess, of severe pyrexial attacks with an initial rigor, or still more certainly the occurrence of pulmonary infarcts and arthritic manifestations, constitute a syndrome so characteristic that mistake is almost impossible. In fact, misdiagnosis is not impossible. One has to think of the diagnosis. The features of Lemierre's is that it classically occurs in a previously healthy child or young adult, and teenagers would be the most common age group for discussion today. It classically follows a non-group A strep infection that may or may not progress to clinically recognizable tonsillar or peritonsillar infection. Several days later, as Lemierre stated, patients become progressively ill with fever, chills, marked toxicity, progressive neck pain, and tenderness over the sternocleidomastoid muscle. And often by the time they return for further evaluation, they have evidence of metastatic infection. They're coughing, they're short of breath, and chest x-rays demonstrate dramatic evidence of hematogenous pneumonia with septic emboli and subsequent empyema formation. Metastatic infection is not limited to the chest. One can see septic arthritis, one can see soft tissue abscesses or necrotizing skin lesions that may mimic vasculitis. And we've had patients referred in with a working diagnosis of acute vasculitis and referred to the rheumatology service who turned out actually to have Lemire syndrome. The infection is not exclusively the domain of Fusobacterium. Other pathogens have been associated with this infection, and most importantly, mixed infections may be responsible. And these may include oral streptococcal pathogens or other gram-negative anaerobes. These patients, when subjected to CBC, almost always have a marked elevation in their white count with a left shift. They're frequently thrombocytopenic, and it's thought that this may simply be due to, quote, sepsis, close quotes, or that there is actually a unique interaction between Fusobacterium necrophorum and platelets. Fusobacterium aggregates platelets and degranulates them, and in the process consumes platelets. This almost certainly is the cause of thrombocytopenia, but equally importantly, the cause for vascular and embolic complications. These patients often are mildly jaundiced, in some cases due to microabscesses of the liver, in other cases due to the liver consequences of sepsis. Renal disease is also seen, again, sometimes due to focal infection of the kidney and other times due to systemic illness. And as I mentioned, the extrapharyngeal and extrathoracic complications sometimes dominate the presentation, and no one really thinks about the sore throat that occurred a week or two before that provoked this diagnosis. A few words of caution, which is that patients sometimes present with neck pain and tenderness over the sternocleidomastoid and are assumed to have cervical lymphadenitis and kind of treated at a lower level of concern than had they been recognized to have thrombophlebitis of the internal jugular vein. In mixed infections, the aerobic pathogens or facultative anaerobic pathogens may grow out before the Fusobacterium, and so they may be treated in a way that A, fails to recognize the diagnosis, and B, inadequately covers the fusobacterial isolate. And remember, most importantly, the pharyngeal findings may resolve before the patient's return with classic Lemire syndrome. This is a quotation from a physician, Cormont, who published 36 years before Lemire, "Be not deceived by a comparatively innocent-appearing pharynx, as the veins of the pharynx may be carrying the death sentence for your patient." Certainly in the pre-antibiotic era, that was an accurate statement, but it showed that this was appreciated as a clinical diagnosis long before cross-sectional imaging. This is a chest x-ray of a teenager admitted to our service several years ago, and you can see the arrows highlight a number of round infiltrates, some of which are suspected of having cavitated. You can see there's pleural disease bilaterally. The CT scan demonstrates classic cannonball hematogenous pneumonitis foci, as well as necrotizing pneumonia and bilateral pleural effusions. These were tapped and turned out to be empyemas in the case of this child, presumably from peripheral infection that traversed the pleural space. This slice of a CT scan demonstrates a clot in the left internal jugular vein. This is not necessary to make the diagnosis, but it certainly confirms the diagnosis when seen when a child is submitted to CT scanning to get a better assessment of the pulmonary process. So the diagnosis was purely at the clinical level for Lemire in terms of history, physical exam, and simple laboratory studies. We've talked about the value of these images. They make for beautiful pictures, but mostly confirm the diagnosis. And equally importantly, point out whether there's something that's drainable and requires the assistance of our surgical colleagues, either at the ear, nose, and throat level or at the thoracic level. Studies with MRI and MRA are often helpful as well because of their beautiful detail. And this demonstrates the presence of a clot in the left internal jugular system, as you can see here, demonstrated by MRA. And this is a patient of ours who actually had an unusual form of Lemire syndrome because she presented with parotitis and wound up having orbital complications and then having neurologic complaints. And as you can see, she had narrowing and, in fact, partial obstruction of the right internal carotid, which reflected vasculitis due to this infection. She improved and did quite well with intensive, prolonged medical therapy. So the treatment assumes the worst. In fact, most fusobacterial strains are penicillin susceptible, but there's no safety in treating with penicillin and being wrong. And so for the modest percentage of beta-lactamase-producing fusobacterial strains, we treat with broad-spectrum therapy. And whether that is through the use of a beta-lactam, beta-lactamase combination, such as ampicillin-sulbactam, or a potent penem agent, such as imipenem or meropenem, the important thing is to recognize the need for broad-spectrum antibiotic therapy. Vancomycin is sometimes added initially as well because of the possibility of concurrent streptococcal infection that may have an elevated MIC to beta-lactams. For patients who are allergic to beta-lactam agents, clindamycin and metronidazole have been successfully used. It's important to drain any collections that we can define through imaging, and that would include the presence of empyema or septic arthritis. In the pre-antibiotic era, ligation of the internal jugular vein was actually performed with some frequency, but it is rare in the current era to have to consider such extreme measures. There has been no prospective randomized trial of anticoagulation in this syndrome simply because of its relative rarity and the inability of a single center or consortium to collect enough cases to do any kind of clinical research. And so the role of anticoagulation is always described as controversial. There are anecdotal reports, in fact, a good number of them, that suggest that the use of heparin is helpful, and it's generally said to be used cautiously. It's worth mentioning that when OBGYN physicians are treating mothers with suppurative pelvic vein thrombophlebitis and pulmonary emboli, anticoagulation is routinely used. Admittedly, they don't run the risk of an intracranial hemorrhage in that situation. It's also important that following recovery, we assess the innate coagulability of these patients, because hypercoagulable states as a risk factor for the development of Lemire syndrome have been identified in several case reports. And it's only when this life-threatening problem develops that we think to investigate their hypercoagulability screen. I'm going to move on and talk about retropharyngeal abscess formation. This is a disease primarily of younger children, typically before kindergarten. We believe that most of these episodes arise from the development of suppurative lymphadenitis of retropharyngeal lymph nodes. Obviously, we can't palpate or examine these nodes, and so it's largely pure supposition. A history of trauma is actually common. This is the age where children trip carrying pencils, forks, toothbrushes, other foreign bodies, and may penetrate the pharynx and get secondary retropharyngeal infection on that basis. It is rare to develop a retropharyngeal abscess in children as a complication of vertebral osteomyelitis, but it has been reported. And it can be an iatrogenic complication following endoscopy or dental procedures. The strategic location of retropharyngeal abscesses produces the symptoms that we associate with this condition. The airway is compromised most importantly. There may be compromise of the esophagus with trouble swallowing and even drooling. The presence of laryngeal edema may compromise the airway directly. And the patients hold their neck in rigid extension to try to relieve pressure on the inflamed tissues. The big concern is, beyond the obvious immediate airway concern, is the development of infection inferiorly, because retropharyngeal abscesses can track into the chest and lead to life-threatening complications. And so you can see in the little schema that the retropharyngeal space sits innocently enough at this level, but if we track down to the level of the thoracic vertebrae number 2, the second thoracic vertebrae, if infection were contained in this space, it would be relatively limited. The problem is that infection can progress posteriorly into the so-called danger space and track deep into the mediastinum. This cross-sectional diagram demonstrates the relationship of the retropharyngeal space to the lateral pharyngeal space in particular, and it's only one fascial plane removed. So infections that complicate tonsillitis or pharyngitis may spread posteriorly and then track directly into the posterior pharyngeal space with the danger space sitting close by. And this linear diagram demonstrates some of the fascial planes involved, and you can see that the anatomy really determines the clinical features of illness. So how do we diagnose retropharyngeal abscess? A lateral neck film is actually quite helpful if a patient can sit quietly in the lateral position to take this picture, because we see that the normal lordosis of the neck is lost, that there is a space developing between the cervical vertebrae and the air column. This represents the phlegmon or abscess in the retropharyngeal space. And sometimes we actually see gas bubbles percolating in this space. A conventional chest x-ray will demonstrate whether or not there's mediastinal widening or the presence of pleural effusions, which would confirm the presence of mediastinitis. But most importantly, we need to obtain CT scanning to demonstrate whether or not the infection has tracked deep into the chest, and if so, are there drainable foci of infection. So in addition to antibiotic therapy, we need to involve our otolaryngology colleagues as well as our pediatric surgical colleagues to decide, A, if something needs to be drained, and if so, which specialty is most appropriate. The details of which antibiotics are best depends a bit on the pathogenesis, but like Lemire syndrome, we tend to involve broad-spectrum therapy and often include vancomycin until we have better microbiological data available. This collection of scans is from a patient who presented actually with pharyngitis complicating mono, had a lot of pharyngitis for a long period of time, had a long course of steroids because of the mono-associated sore throat, and then presented acutely ill. And as you can see on her scan, she had air tracking lateral to the trachea and had widespread mediastinitis. She had an empyema. She spent about 3 months in the hospital ultimately did quite well, but had a very morbid hospital course. I'm going to move on to talk about sinus infections and their complications. I'll say a word about their anatomy and then try to define and show some pictures that may help to distinguish between periorbital and orbital disease and some of the more concerning complications. This diagram shows the location of the paired sinuses and points out that their position really abuts the orbit, that the superior, the medial, and the inferior borders of the orbit, in fact, are the walls, the lateral walls or inferior walls of the respective sinuses, as you can see. Most importantly, the lateral wall of the ethmoid sinus is paper thin and has been named so at lamina papyracea. And in some patients, it's really incomplete. It's not even a true bony barrier. And so infections in the ethmoid can spread laterally into the orbit with marked ease. This picture, first of all, I have to mention that child has had ophthalmological evaluation and has had dilating eye drops put in. So let's ignore the pupils. But this would be a classic presentation for periorbital cellulitis or preceptal cellulitis. There's erythema, there's swelling. But if this child were here with us today and we could ask him to demonstrate eye movements, we would see that there's intact eye movement, there'd be intact acuity, and there's no proptosis. The globe is in its proper position. The mechanism of periorbital or cellulitis or preceptal cellulitis is that the inflammation in the ethmoid leads to impaired venous drainage, and as a result the adjoining tissues swell, and the degree of inflammation determines how inflamed they appear on appearance. The lid edema is not tender, the lid is not cellulitic, and as I mentioned, motility and vision are normal. This can be the result of an insect bite or on occasion due to dacrocystitis. As you can see in this picture, the lacrimal gland sits here, and the lacrimal duct is obstructed and drains purulent collection from the punctum. When you see a patient whose photograph looks like this, the question is, well, at what level is the infection? We have trouble seeing the globe here, of course, and so we don't know if there's proptosis suggesting a deeper process, or in fact this is just a more severe case of periorbital cellulitis. In this photograph, we can see that there's marked lid swelling, and there's also proptosis, and this clearly says there's been orbital disease in the making. So orbital cellulitis, using the same orienting diagram, represents infection that typically starts in the ethmoid sinus and spreads laterally into the orbit. So there's cellulitis of the orbital soft tissue, but no frank abscess. The lid edema is often tender. There's now forward movement of the globe because of the inflammatory mass in the posterior aspect of the orbit. There's chemosis, if you were to be able to look at the conjunctival tissues in this patient. Extraocular motility is typically compromised because the muscles, the extraocular muscles, are now getting pinched by the soft tissue swelling. And so even though visual acuity is preserved, the patient often presents with diplopia in addition to the other symptoms that this may produce. And this requires drainage of the ethmoid infection. There really is no drainable orbital process here. But these patients are watched with hopes that following ethmoid drainage, the orbital manifestations will improve. In contrast, a subperiosteal abscess arising from the ethmoid ruptures laterally into the orbit, but the orbital, the periosteum of the lamina papyracea holds the infection in place. And although there is potentially proptosis and displacement of the globe, this is still an ENT drainage procedure, not an ophthalmologic drainage procedure, because ethmoid drainage will remove this collection and allow the orbital structures to resume their normal position. And this collection of CT images demonstrates that you can see a very discrete subperiosteal abscess arising from an infected ethmoid here, and you can see again this ethmoid is totally opacified with infection that has ruptured laterally into the orbit. There is mild proptosis and soft tissue involvement in the orbit without an additional drainable collection. In contrast, frank orbital abscess formation can develop if infection spreads microscopically from an infected ethmoid sinus into the orbital tissues. The presence of an abscess in this very delicate location leads to proptosis, leads to ophthalmoplegia, and commonly leads to impaired visual acuity. This is an ophthalmologic surgical emergency if there's a true abscess defined on imaging or orbital ultrasound. And this demonstrates a finding in that context. Sphenoid sinusitis is a clinical problem because we don't really appreciate sphenoid sinusitis well. Because of its deep location at the base of the skull, the localization of pain is poorly described. And so the so-called classic vertex headache as a sign of sphenoid sinusitis is actually present in only a small fraction of patients. The walls of the sphenoid sinus, like the walls of the ethmoid, are relatively thin, and they sit next to important structures, as I've listed here, including the optic canal, the cavernous sinus, the dura, and the pituitary. Not a good place to have a deep infection, which is not easily recognized. Sphenoid sinusitis is commonly the major risk factor for the development of cavernous sinus thrombosis. The cavernous sinus is a very complex venous structure that has a number of critically important neurovascular components traversing right through the space. And so I've listed here that the internal carotid and the sixth cranial nerve traverse the cavernous sinus medially, and that cranial nerves 3, 4, and 2 branches of the fifth cranial nerve traverse the space laterally. Most importantly, the cavernous sinuses communicate with each other through a venous plexus that is known as the intracellular intercavernous sinus. And so infection in one cavernous sinus commonly can spread through these intercavernous sinuses to the contralateral side, producing bilateral cavernous sinus thrombosis. Remember that these vascular structures are impacted not only by sphenoid sinus disease, but also by facial infections in the midface, because the veins that drain the midface have no valves, And so any infected material that reaches the venous drainage system can actually enter the cavernous sinuses fairly directly. This is a CT scan of the patient whose picture I showed a few slides ago. And you can see that there's an orbital abscess, there is proptosis, there's superficial inflammation, and that there's bilateral sphenoid sinus involvement. And this demonstrates the nature of the cavernous sinuses. You can see they sit basically left and right of the pituitary stalk, and the pituitary stalk is surrounded by a venous plexus that connects the two cavernous sinuses. And so if we keep this in mind as we look at a coronal image, you can see that here's the sphenoid, and sitting immediately superolaterally to it is the cavernous sinus with all of those critical structures sitting within, and that the intracranial space is sitting just lateral to the cavernous sinus as well. So this is a very high-risk infection because of the risk of spread into the cavernous sinus, leading to thrombosis and all the complications that follow. So patients will have initial unilateral symptoms and findings, but notably will develop progression of their complaints from the original eye of involvement to have bilateral eye findings with double vision because neither eye is moving. There's now inflammation involving both orbital spaces. And because of this strategic location, patients can develop a variety of life-threatening neurosurgical infections. They can develop an epidural abscess. They can develop a subdural empyema. They can have frank meningitis. They can have strokes because the penetrating vascular supply to the base of the brain comes off the circle of Willis right near these structures. And they can have transient or permanent damage to the pituitary. In terms of microbiological etiology, most of these cases represent complications of acute sinusitis. And so I've listed some of the typical pathogens, Staph aureus, Haemophilus influenzae, often non-typable these days, the pneumococcus, other streptococci, anaerobes, and if there's a history of prior chronic sinus disease, we will see more anaerobes and Enterobacteriaceae. Remember that Strep Milleri or Strep Anginosis is a normal denizen of the oral pharynx and may find itself in the microbiological flora of the sinuses in the setting of infection. Strep Anginosis or Strep Milleri is classic in its ability to form abscesses, and so complications that follow are often associated with sphenoid sinusitis, ultimately due to a mixed infection containing Strep Anginosis. Mixed infections are common, and as if that weren't bad enough, it's worth mentioning that in patients who've had chronic sinusitis, that they may in fact have fungal disease as well, that Aspergillus has been a cause of chronic sinus infection or a secondary invader of chronic sinus disease in normal hosts, and that in patients who are immunocompromised, that mucor may produce a hyperacute syndrome of sphenoid sinusitis with intracranial complication. The medical therapy is going to be intensive and broad spectrum to cover the list of potential pathogens and hope that we didn't miss anybody. And so vancomycin, together with ceftriaxone and anaerobic coverage in the form of metronidazole, or vancomycin with a penem agent such as meropenem, would be appropriate initial therapy. These patients are treated for prolonged courses of therapy, and if possible, patients should undergo drainage of the feeding focus of infection. We generally like to wait at least a short while to start antibiotics and try to control the risk of spread of infection. But within 24 hours of starting antibiotics, if the patient's stable enough to wait, one would want to have appropriate drainage of the feeding focus of infection. Not only does that involve draining the sinus, but one would also, of course, need to drain any metastatic or secondary infections that spread primarily from the sphenoid sinus. In terms of adjunctive measures, just as in Lemire syndrome, the role of anticoagulation is often discussed and often debated, but again, there's a paucity of data to really guide us. In this case, one has real concerns about the risk of increased intracranial pressure and the risk of intracranial hemorrhage if a patient were vigorously anticoagulated. It goes without saying that anticoagulation should be timed with surgery, and that is not to be given before the patient goes off to the OR, but at a safe interval following surgery. And we often have our hematologists fine-tune the anticoagulation aspect of these patients. Dexamethasone has been given as an anti-inflammatory agent in these patients in hopes of protecting against infarction of the cranial nerves with permanent visual and oculomotor complications. It may also protect against acute adrenal insufficiency in the case of pituitary insufficiency. I'm going to move now to speak about I guess more ear than eye infection and say a few words about mastoiditis. I think the key anatomical consideration is that the mucosal lining of the mastoid is part and parcel of that of the middle ear. So when children present with what seems like uncomplicated acute otitis media, by definition the mastoid is seeing the same inflammatory fluid that the middle ear space is seeing, because it's really one hourglass-shaped space. As with the sphenoid sinus, the anatomic localization of the mastoid is quite strategic, because right above it sits the middle cranial fossa, posteriorly sits the posterior cranial fossa and the sigmoid sinus, and anteromedially sits the middle ear, the facial nerve, the carotid sheath, and anything else you want to say. And it's also abutting the hearing sensory organs as well. We distinguish between two forms of mastoiditis. The mastoid may simply fill with inflammatory fluid in the case of otherwise uncomplicated otitis media, or infection can really get stuck there, leading to the development of mucopurulent exudate that ultimately destroys the delicate bony septations that are present in the mastoid. And ear, nose, and throat surgeons commonly talk about coalescent mastoiditis versus medical mastoiditis because of the bony destruction in the former, which defines the need for surgical drainage. This anatomical drawing demonstrates that here's the middle ear. The connecting space is called the adductus. This is the antrum of the mastoid. And you can see this is all one space. And so we never think about a child with uncomplicated otitis as in fact having mastoid inflammation, but it really happens. And if the infection spreads into these myriad cells and is localized there, leading to bony destruction, we are now confronting surgical mastoiditis. Children present with ear pain, with tenderness behind the ear, with swelling, and classically with proptosis of the pinna. And when you see this once, you really don't forget it. And I'll show you a picture so that you will have seen it. The systemic features are often not so impressive because children often come to the emergency room or to a referral office after receiving a course of antibiotic therapy. The term Bezold abscess defines a soft tissue collection of purulent material that represents drainage from a subperiosteal collection starting out from the mastoid bone, and can in fact track almost anywhere in the head and neck space and ultimately be shown to be a Bezold abscess. As I've listed here, there are a number of intracranial extensions that follow from its anatomic location. Again, these are all quite serious and frequently require intervention. But the proptosis, the unilateral proptosis, often with erythema and marked tenderness and often fluctuance posteriorly in the retroauricular space, accompanied by large retroauricular tender nodes and the presence of otitis media when this child undergoes otoscopy, makes the diagnosis. The management is an easy clinical one because of the proptosis in the setting of acute otitis media or recurrent otitis media, or appreciation or recognition that a soft tissue collection is in fact a Bezold abscess and not an incidental subcutaneous abscess due to MRSA or some other unrelated process. patients can present with intracranial or local spread at the time of initial diagnosis. In patients who don't respond promptly to intravenous antibiotic therapy, we often obtain a CT scan to see if they have this classic coalescent destruction and need for surgical treatment. This CT scan represents that of a child, a teenager actually, who was sent in with an unclear central nervous system infection, and this turned out to be a subdural empyema. And as you can see, this is an infection that's localized to the potential space between the dura and the subarachnoid membranes. Because there are no anatomic barriers in that space, infection spreads rapidly and can involve the entire convexity of the brain, can cross the midline and contract down around the falx. Most of these patients have complications of sinusitis as the cause of their infection, although some patients may, in fact, have otitis media leading to spread of the infection to the subdural space. We can see this after trauma, head trauma, penetrating head trauma, or after neurosurgery as well. And in infants who have pyogenic meningitis, this can complicate the common development of subdural effusions that we can see in this situation. So many children of young age who have meningitis will have subdural effusions. A small fraction will actually have subdural empyemas requiring drainage. So imaging is the first diagnostic study because a CT scan or an MRI will demonstrate the problem. We prefer to do that before tapping because of the concern of increased intracranial pressure and the risk of potential herniation. The spinal fluid, when tapped, is generally sterile and has a classic parameningeal formula with elevated protein, minimal deviation of the sugar, but the presence of granulocytes predominating, or at least being a significant fraction of the white cells that are present in the spinal fluid. These patients are started on broad-spectrum antibiotics and subjected to drainage by our neurosurgical colleagues. And whether that's limited to a single burr hole or more aggressive craniectomy depends on the extent of the fluid collection and how widespread it is and how successful the surgeon might be in draining it in a limited basis. And as I mentioned, the deep collections that involve the midline may require multiple procedures because it's just hard to get to. A word about epidural abscess as opposed to the subdural infections. This is a little bit more superficial. It's localized between the skull and the dura mater. Because of the tight relationship between the dura and the inner table of the cranium, infection doesn't spread so widely as it does with subdural collections, and the abscesses are usually limited in location to the initial focus of infection, classically in relation to the sinuses or to the mastoid. Now, these patients often present in a more indolent fashion, and they mostly present with symptoms of their primary infection, typically sinus disease or headache, until they clearly get somewhat more ill or have a seizure or some other dramatic sign. And as I mentioned, the scan usually tells a story. In this case, you can see that there's asymmetric inflammation and a small collection abutting the frontal sinus, which has thickened membranes here, but is otherwise not all that impressive looking at the time this picture was taken. A word about lateral sinus thrombosis. The lateral sinuses are frequently asymmetric, and they don't talk to us much, and we don't speak to them much until they undergo thrombosis and lead to trouble. If one of the lateral sinuses undergoes thrombosis, it impairs spinal fluid resorption and produces headache, so-called otitic hydrocephalus. So a child will have an ear infection or recurrent otitis media and then develop unremitting headache and turn out to have thrombosis of the ipsilateral lateral sinus. Infection can also be due directly from the mastoid, which spreads to the epidural space, which in turn abuts the lateral sinus, leading to a lateral sinus thrombosis. And this diagnosis can be made or confirmed by cross-sectional imaging, either by CT scan with CT angiography or by MRI with contrast. And you can see that the left side here has no flow. And so this was thrombosed. And This then defines the problem, leading to anticoagulation and antibiotic therapy and drainage of the feeding focus, such as the mastoid, if present. So these patients present with progressive headache and then develop signs of increased intracranial pressure. They may have fever. They needn't have fever. And the extent of central nervous system symptoms depends on how far along the process may be. Remembering that sixth nerve palsies don't necessarily reflect compromise of the sixth nerve directly, but simply of increased intracranial pressure as the longest of the cranial nerves, tries to reach the orbit. Patients may or may not have papilledema, and sometimes we can identify the initial focus of infection, as I've noted here. And so we try to lead to drain the mastoid if present. I will close by just reviewing the introductory key points, which is that head and neck infections are actually rather common. For example, mastoiditis occurs in about 1 of 1,500 cases of acute otitis media. It may not be a lot for an individual pediatrician, but for a busy practice, it starts to add up. These complications are rare, but potentially life-threatening because of their strategic anatomic localization. Imaging, multidisciplinary assessment, and recognition of mixed infections and the need for broad-spectrum antibiotics are common themes among all of these infections. And as we deal with more and more resistant microbes, we really have to be more and more aggressive in the use of antibiotic therapy to avoid medical failure with